Okay, good afternoon, dear ladies and gentlemen, dear colleagues. Welcome to our newest CUPID scientific webinar. Today is May 10th, 2024, and I would like to welcome all colleagues which are now together with us. Let me say a few words about this webinar, and after that we will start. Many external and internal factors influence healthcare engagement among people with intellectual disabilities, resulting in long-term health consequences. External factors include diagnostic overshadowing, paternalism, and cancer screening delays during the COVID-19 pandemic. For the person, challenges with communication, cognitive ability, and decision-making capacity influence healthcare engagement. It is timely to develop collaborative links with the EU research and service provider communities to reach consensus and on addressing these challenges. CUPID establishes active working partnership with academics, researchers, non-governmental organizations, carriers, people with intellectual disabilities, and policymakers. CUPID annual conference in the frame of the Working Group 4 activities was organized on November 15th last year. And this is our second big event, which goal is dissemination of CUPID activities. For this webinar, we had 138 registered participants, which is a respectful number of interested colleagues. What are our key activities? Working Group 4 focuses on the dissemination of the action and its activities and deliverables through a purpose-designed, accessible website, social media platforms such as Facebook and X platform, blogs, LinkedIn, open access journals, newsletters, accessible information reports, and infographics, and YouTube videos. Please turn off your microphones, or I will ask the host to turn off all microphones. The Action's website and social media networks serve as a main communication channels between Action members and all relevant parties, researchers, clinicians, healthcare providers, intellectual disability organizations, advocacy groups, policymakers, screening staff, people with intellectual disabilities, and carriers. Deliverables which we achieved in last 18 months during this action. We organized 2 meetings in person, 4 meetings online, developing CUPID logo banner, developing 2 infographics, developing modern and accessible CUPID website, which I will share afterwards in the chat, developing social media, Facebook, X, Instagram, LinkedIn, and YouTube channel, developing a PowerPoint template for conferences presentations, developing several posters, published 4 articles. Today, we will have 4 interesting topics. Let's start with the presentations. Before that, I want to tell you that this webinar is streaming on CUPID YouTube channel. And according to the GDPR, afterwards, in the session of questions and comments, if you don't want to appear with camera, you don't need to do that, because for our purposes for dissemination, we must share this webinar on our YouTube channel, and also the print screens from the presenters will appear afterwards on our social media. Now, I will ask the presenters to keep the time on 13 minutes and to leave 2 minutes for discussions. After all 4 presentations, there will be time for questions and comments. So, firstly, I'm inviting Dr. Katarzyna Ćwirynkało and Dr. Agnieszka Żyta from Poland to take the floor, and they will present the topic with entitled as Cancer Prevention as Described by Person with Intellectual Disabilities, a preliminary research report. I hope that all of you will enjoy in this very interesting for presentations. I have opportunity to see the presentations before this webinar. So we can start with the first one. Dr. Katarzyna Ćwirynkało, please start. And also I can ask the other presenters it will be better to turn off the videos and camera and to mute the audio. So only the presenter should appear on the screen. Please, all of you, turn off the camera and the audio. Okay, please.
Thank you. Thank you very much, Professor Trajkovski. Good afternoon, everyone. We are very happy that we are all here together. In this presentation, we will tell you about the study that we have been working on in the last 4 months. We have not prepared the final report yet. This is just a preliminary research report, but we have already finished the stage of collecting data.
Please go on. Please go on, Katarzyna. Turn on the microphone. Turn on the microphone because someone muted all them. I will repeat again. Dear participants, please turn off your microphones. За колегите от Македонија и колешките ве молам, исклучете ги микрофоните. Please go on.
Okay, I hope that you have heard what I said on my first slide, so I'll start with the second one. So these are the authors of the presentation. Some of you already know me and Professor Agnieszka Żyta. We are working at the University of Warmia and Mazury in Olsztyn, Poland, but there is also another co-author who worked with us on this research, and this is Professor Monika Parchomiuk, who works at the University of Maria Curie-Skłodowska in Lublin. To start with, we would like to focus on the rationale for our study. First of all, it needs to be emphasized that people with intellectual disabilities face an elevated risk of numerous diseases, such as diabetes, epilepsy, asthma, but also cancer. And they are also more likely to be hospitalized and to have a significantly shorter lifespan. Yet they still experience inequalities, and their views about cancer and cancer prevention have been given scant attention. In our study, we wanted to change it. As Miranda Fricker notices, all people should have the right to be heard, taken seriously, and to contribute to knowledge production. This refers to groups which are likely to be marginalized. The credibility of people with intellectual disabilities is often undermined in research, which means that important knowledge isn't shared, and to an ethical one, which means that the knower is harmed. Our study was inclusive in nature. Co-researchers with intellectual disabilities were actively engaged in every stage of the study. Their contributions encompassed assisting academic researchers, which means us to direct our focus appropriately, facilitating contact with other individuals with intellectual disabilities, providing assistance with developing interview guidelines, and conducting interviews and data analysis. In this photo, you can see our research team. This is not the whole research team, but we actually really met all together. More commonly, we worked in smaller groups, in pairs. For example, when we conduct interviews, there is always one co-researcher with intellectual disability and one academic co-researcher. The aim of our study was to gain understanding on how people with intellectual disabilities perceive cancer and cancer prevention. To achieve this aim, we conducted individual interviews and analyzed them. The study was, of course, granted an ethical approval from the Institutional Review Board of the University of Warmia and Mazury. Agnieszka will tell you a few words about the study group. Agnieszka?
Yes, I hope I'm here. The study group consisted of 44 people, 24 women and 20 men, aged between 21 and 64. The average age of our interviews was 38 years. All persons are people with intellectual disability. 33 people attend 3 occupational therapy workshops, 1 in Ostróda and 2 in Lublin. Ostróda is in the northeast of Poland. Lublin is a city in the southeast of Poland. Some of our people we interviewed work in vocational activity center in Ostróda. It was 11 people. 14 people interviewed have addictional disorders, motor disability, epilepsy, sensory disability, speech disorders, neurological and mental illnesses. 18 of our interviewees are residents of rural areas, 14 people of small towns, and 12 people are from cities. Only 2 persons live alone, 1 with a wife and their child, 5 persons with legal guardians or extended family. 36 people live with parents. None of the study group live in a social welfare home. 1 of the women has experienced a cancer. And it's all about study group. Thank you.
Thank you, Agnieszka. Thank you very much. I will go forward. In the process of analysis, 4 superordinate themes were generated, and these are, as you can see, meanings ascribed to cancer, cancer prevention awareness, my own experience, when referred to people with intellectual disabilities, and what needs to be done. As far as the first theme is concerned, we would like to emphasize that for many participants, cancer was a difficult subject to talk about, either because it was associated with negative emotions and negative feelings, or because of lack of knowledge about it, and that was also difficult for them. Some interviewees reported that for them, cancer is associated with death, suffering of a sick person and suffering of the whole family. They also talked about pain, destroying a person from the inside, or about sick cells, or they referred to the appearance, for example, talking about baldness of a person who has a cancer. Others talked about certain types of cancer, such as breast cancer or lung cancer. These were the most common, and some also mentioned hospital and treatment, particularly chemotherapy. The second theme related to cancer prevention. Most participants were able to identify 1 or more ways to prevent cancer. They talked about going to a doctor, doing screenings. They even talked about different kinds of screening necessary to avoid cancer. They talked about eating healthy food, the need not to smoke and not to drink alcohol. A few people also mentioned that it is not allowed to go sunbathing without sunscreen creams. We can also add that people we interviewed did not know, some people did not know the word prevention. That was quite difficult for them. And if that was the case, we explained the word or just exchanged, asking, for example, how can we stay healthy, or what can we do to prevent cancer? Next topic referred to people's experience. As Agnieszka already said, only 1 person had a cancer, 43 did not. And participants talked about the various approaches to screenings. Only a few of them undergo regular screenings and checkups, for example, go to mammography. They also have diverse approaches to a healthy lifestyle. It can be stated that there is generally high awareness, but frequent difficulties arise in adhering to healthy lifestyle practices. Some people also talked about their close relatives who suffered from cancer. This was often a traumatic experience for them. They described what they looked like, for example, that they were thin as skeletons or that they were bald. Sometimes these descriptions were accompanied by fear, but also by exclusion and lack of information. It is possible, in our opinion, that families of these people wanted to protect these people with intellectual disabilities and did not allow them to have contact with person with terminal disease. According to most of the participants, it is necessary to raise awareness among people with intellectual disabilities. An interesting category referred also to raising awareness among parents of people with intellectual disabilities. Furthermore, some people concluded that changes in healthcare of people with intellectual disabilities is necessary. They wanted healthcare professionals to become more friendly and the whole system of accessing healthcare to become more friendly. In conclusion, we would like to highlight that some participants in this study had not heard of cancer at all. However, this does not imply that they did not prioritize their health. At times, their focus was primarily on managing existing health conditions that required treatment. For those who were aware of cancer, it was often associated with negative descriptions and negative emotions. Additionally, many were unaware of the importance of cancer prevention efforts. Moving forward, we don't want our research to fail into research on participants, as Dan Goodley said, when the only person benefiting is the researcher and their career aspirations. It's not just for us. At this point in time, it is not very clear how the conclusions of our study will influence practical action that involves people with intellectual disabilities. But as we stated here on the slide, we plan to organize workshops on cancer prevention for participants of our program. Actually, the first training will take place on the 27th of May, so quite shortly. We have already prepared something, and they will be prepared in collaboration with specialists and co-researchers with intellectual disabilities. Furthermore, we have prepared an easy-to-read article detailing the activities we undertook and hope to publish it in a magazine affiliated with the Polish Association on Persons with Intellectual Disabilities. And on the next slide, you will see this easy-read texts. I translated them into English just for you to have a look at what it looks like. We have already published two similar easy read texts in this magazine and hope that it will be the next. Okay, so these are the references that we used here, and I would like to thank you very much for the attention.
Yeah, thank you very much, dear associated professors, Katarzyna and Agnieszka. Very interesting presentation, a preliminary study in Poland, and your contribution from Poland as a Polish group is very fruitful in the CUPID action. So in this at this moment, we have time only for one question, if there is one. You can, for the audience, you can turn on your audio. You can turn, you please raise your hand if you have a question or comment. And you can appear with camera or only with audio, with your microphone. Or the third option is to put your question on the chat. platform. Is there anyone? I cannot see, but probably at the end of the today's webinar, there are 71 participants on this moment, and I think that probably there will be one question about your Polish preliminary study, and you have a very nice prepared, easy-read text. Thank you for translating on English. You can send me after this webinar the photos of that, and we can share it on the social media, on CUPID social media. Okay, dear ladies, we are going. Thank you very much. You can go off with your camera. Now I will announce the second speakers for today. Dr. Margaret Denny and Dr. Suzanne Denieffe. They will talk to us about the co-production process in CUPID. One of them, for those who are not involved in CUPID, Dr. Suzanne Denieffe is the actual chair of the CUPID project, and Dr. Margaret Denny is the lead of Working Group 1. Please go with your presentation.
Professor Vladimir, thank you so much for giving us the opportunity to present here today. So I'm just going to share our screen. Can everyone see that, I hope?
Yes, please start.
Yes, so our topic is on the co-production process in the CUPID project. So the overall goal of the CUPID project is to improve cancer prevention efforts for people with intellectual and developmental disabilities. So co-production is a really important element of the CUPID project because we believe that people with ID and developmental disabilities needs are better met when they are involved in an equal and reciprocal relationship with professionals and others, so that we are all working together to improve cancer prevention across Europe. So what is co-production? Co-production is an approach where everyone, people with intellectual disability, their family members, their carers, organizations and researchers and academics all work together in an equal way, sharing influence, skills and experience to design, deliver and monitor services and projects. I'm going to introduce the ladder of co-production. Some of you may be familiar with this ladder already, but this ladder of co-production outlines the various levels of co-production. So I'm actually going to start at the bottom of the ladder. At the bottom of the co-production ladder is coercion. This is where people's views aren't considered at all. And we would provide services to people with intellectual disability and just expect them to use them. Education is the next step in co-production, as in the next possibility. Education is where service users are helped to understand cancer prevention and services, but nothing further is done other than giving them information. At the informing stage of co-production, those responsible for organising services explain to people how services work and how decisions are made, but they don't really involve them. In the consultation stage of co-production, people might be asked to fill in surveys or attend meetings, but sometimes this is very tokenistic because the people provide their views, but they've very limited power to influence or affect change. Engagement is where people who use services are given opportunities to express their views, and they have some influences over decisions. Co-designing is where people with intellectual disability might be involved in designing a project, giving their experiences and ideas, but they are not involved in the full process. But what we're seeking in CUPID is to have true co-production, which is the top of the ladder. And in co-production, there's the equal relationship between the people who use the services and those responsible. And they've worked together on the whole process, designing and delivering, making decisions about the best way to undertake projects or to deliver services. But co-production isn't easy. And there are many possible barriers. And barriers include, like, who has credibility, who sets agendas, what language is used, particularly if we're going to be using, if we're going to be able to communicate with people with ID, we need to do so in a language that they will understand and be able to use. We have to consider people's time and payment, perhaps, to involve people with intellectual disability. We have to consider accountability and responsibility, the venues used, the accessibility of the venues used. So there are many, many barriers to co-production, but it's up to us to try identify those barriers and overcome them. So I'm going to hand over now to Margaret, because she's going to talk to you about the 5 principles that people can bear in mind if they're doing co-production. Margaret.
Good afternoon, everybody, and thank you, Professor Vladimir, for affording us this opportunity to present on co-production. So the 5 principles which help CUPID engage in co-production are: 1, the strengths of the team, really. Everybody has strengths and weaknesses. Everybody has skills, knowledge, experience, and other qualities to offer. And indeed, everyone is needed to produce solutions that work, and that includes people with intellectual and developmental disabilities. The second principle is power. It's difficult for people with developmental and intellectual disabilities to challenge how things are done alone. And Vladimir spoke already about diagnostic overshadowing, which is a key feature in terms of a diagnosis if somebody presents with cancer. And they probably feel disempowered, as do their family members and their significant others or carers. So all types of power must be shared. Leadership, support, and resources must come from everyone involved. Unequal power needs to be recognised and addressed. The third area is relationships. Good relationships are crucial for working together. So this involves all members of CUPID, including service organisations and all those we're involved with, and especially people with intellectual and developmental disabilities. Positive relationships require time, respect, and trust. Actually, it's a moral response on our behalf. Everyone needs to feel safe, valued, and wanted, and the process must feel fair, open, and honest to everyone. Diversity is the 4th principle. Diversity of people is important for high quality thinking. The process of working together, the language must make sense to everyone involved. Inequalities must be identified and talked about. These might link to age, class, disability, education, race, religion, sex, or sexual orientation. And the 5th and final one is knowledge. There are different ways of knowing things, and all of them are valuable and should be valued by everybody. Experiential, formal knowledge, whatever that type of knowledge may be. First-hand experience is as valuable as professional or academic knowledge. Knowledge of what does or does not work in the real world must be recognised and valued. So, critiquing our use of these principles in CUPID, we have started, but we can do better. For example, the project was not written including people with intellectual or developmental disabilities, but all working groups can, going forward, ensure they follow these principles. We need to get more people with intellectual disabilities, their carers, significant others, family members, organisations involved in CUPID. We need to increase our membership. We need to support them to get involved, and we're doing this in the training school. So the training school and co-production, people with intellectual disabilities and their carers have been invited to attend as equal cost members. And this indeed didn't happen easy. We had a long journey in terms of the planning phase and how we would get people involved in the training school. All session materials will be prepared in easy read, and Dr. Denieffe has already gone out to services to actually look at the surveys we're going to undertake, the easy read documentation, and she has verified that with service users or people with intellectual disability. And I'd like to thank her for all the work she has done in helping us to achieve this level of co-production. During the sessions over 3 days, we will learn together about cancer prevention and screening, looking at people with intellectual disabilities and their information needs, their views, their supports and resources available. We will ensure that the principles of co-production are adhered to. So in terms, if we go back to that ladder of co-production, if we apply the ladder framework, we have we have consulted with services, that's indeed number 4. We have engaged them, that's number 5. We aspire to co-design and ultimately co-production, both during the training school and in the lifetime of the CUPID project, and indeed in the future. Thank you for listening.
Thank you very much, dear Assistant Associated Professors Suzanne Denieffe Barry and Dr. Suzanne and Dr. Margaret Denny. Co-production is crucial in each project and in CUPID as well. And you are the leader in this project as Irish colleagues, and because the SETU University is really the leader, and your contribution in this project is very valuable. So this presentation and the forthcoming summer school in September, I hope that will enrich the goals of this project, and especially because you planned you plan several people with intellectual disabilities to be there together with scientists, researchers. Are there any, I don't want to take the time, are there any questions or comments at this stage? Only one comment, or I'm very grateful because there are not only people from CUPID participants, we also have a lot of colleagues from outside of the action, and it's good for the dissemination of our project. Probably they are shaming. Please don't shame. Okay, we will at the end you will have again opportunity to say a few words if you want, Dr. Denny and Dr. Denieffe Barry.
Yes.
Now we are going, please turn off your microphones and camera. We are going to the third presentation for today. Dr. Lara Carneiro and her colleagues. I will put them in the chat, all the names. She will present the management of cancer and depression in people with intellectual disabilities, an overview study. So please go on with your presentation.
Thank you so much, Professor Vladimir. Good afternoon, everyone. I hope you are doing well today. So I will present, my topic is about the management of cancer and depression in people with intellectual disabilities. And before starting, I'd like to highlight that this presentation is based on a chapter that it was written by several authors, as you can see here. So just a brief introduction. From a historical perspective, before 1980s, people with intellectual disabilities were regarded and cognitively unable to have a mental illness. It means that before 1980s, mental illness symptoms were seen as part of the illness, as part of the ID. However, currently we know that several studies have confirmed that, of course, psychiatric disorders are separate entities from intellectual disabilities. And it is accepted that persons with ID can experience not only the psychiatric disorders, can experience psychiatric disorders like mood disorders or anxiety disorders, eating disorders, independent of their ID diagnosis. And two of the psychiatric symptoms most frequently reported by people with ID are depression and anxiety. And if we compare with people without the condition, is similar. However, when we compare people with ID and people without the condition, we know that in people with ID, they feel they have higher risk of developing anxiety. And depressive disorders has been reporting as occurring more in people with mild to moderate disability when compared with severe or profound disabilities. But this might be a measurement problem. As you know, that people with severe and profound levels, they cannot express, most of them cannot express themselves in the way they would like to do. So they cannot express feelings, emotions, and this is a measurement problem. Another thing that I'd like to highlight is that there is a huge interconnection between physical health and mental health. We know that the first cause of death in this population is cancer, but the second one is coronary heart disease. So the risk factors for coronary heart disease are lack of physical activity, poor nutrition, tobacco. So, and poor physical health increases the risk of developing mental health issues. And when diagnosis is dual, when the person has the ID and developed cancer and a psychiatric condition, okay? In this case, can be depression, major depressive disorder, that is the most prevalent type of depression. So people in these circumstances are underdiagnosed and often poorly treated. Okay, and this diagnosis of mental disorders in people with ID is highly complex due to their inability, and as I have already mentioned, to express feelings, emotions, pain, their thoughts. And depressive symptoms are highly heterogeneous. Okay, if you speak about major depressive disorder, that is the most prevalent type of depression, we know if you have two people, one can have typical symptoms, classical symptoms like depressed mood, sadness, loss of interest, fatigue, but you can have another person that can show atypical symptoms like anger and irritability. And this is one factor. Another one is that assessment of these symptoms in cancer patients can be difficult due to confounding factors between cancer and depression. For example, we know that fatigue is a symptom of major depressive disorder, but fatigue is also a secondary effect for someone that is undergoing treatment for cancer. For example, chemotherapy and radiation therapy. And another point that I'd like to highlight is that depression disorder has a very broad spectrum, and this makes diagnosis even more challenging. So it ranged from mild to severe. The causes, there are several causes that can lead to depression, the genetic predisposition, in chemical balance in the brain, lack of serotonin, lack of dopamine, can appear as a psychiatric comorbidity of someone that has a main condition, for example, cancer. So this makes the diagnosis challenging, as I have already mentioned. But the knowledge about no pharmacological treatment is scarce in adults with ID. However, you know that the most acknowledged no pharmacological intervention of therapy for depression in people with ID is CBT, cognitive behavior therapy. But cognitive behavioral therapy has to be adapted for this specific population. If they are not able to express themselves verbally, so we need to try to recognize or to give them the opportunity to speak with non-verbal language like signs, gestures, through pictures, for example. So challenges. Some authors suggest that psychiatrists tend not to diagnose psychiatric disorders in people with ID, which might be diagnostic overshadowing. Dr. Margaret has already discussed about it. Another factor is limited appropriate assessment. Why? Many people with depression and ID may not meet the diagnostic criteria, using DCM, DSM-5 or DMID due to constraints in verbal self-reporting of symptoms. So there is no single and best tool to measure depression in people ID. The best approach might be to have different tools, BDI, Beck or Hamilton, or clinical interview to try to avoid or minimize diagnostic overshadowing. Challenging behaviors can be linked with other psychiatric disorders or conditions. We know, for example, in measure depressive disorder coexists several times with anxiety disorders, okay? And this can lead, or this can make the diagnosis, again, more challenging. It is crucial to be aware that symptoms of depression in this specific population can be typical, and the most prevalent symptoms are concerning major depressive disorder are sadness, mood fluctuation, and crying. But if you compare people with ID with people without condition, we always know that they can show atypical symptoms like physical complaints or reduced speech. Recommendations. Guidelines for assessing different levels should be developed, as most available treatments options focus only in mild intellectual disabilities. The second point is important to promote a healthy lifestyle. As I have already mentioned, the first cause of death in this population is cancer, but the second one is coronary heart disease. Many individuals with ID are overweight. They don't engage in physical activity according to the World Health Organization guidelines, that is 150 minutes per week. And all of these factors increase the risk of some cancers. On the other hand, we know that poor mental health leads an increase of risk of developing psychopathologies. Cancer prevention and screening people ID is paramount. We know that most of the people with ID are diagnosed in a later stage, but we also know that they face several barriers in cancer screening, like distress, perceptions of fear, and lack of knowledge about cancer screening. Another key point that I like to stress is that because of significant overlap between physical health and mental health issues in this population, it's important to conduct a thorough, meticulous, and differential diagnosis. Something has happened. Okay. So, well, it is essential to offer treatment to people with ID, and once depression is diagnosed, they should be offered special treatment aimed at depression and also with the aim to reduce stress. Healthcare professionals should have specific training, not only in the cancer as a disability and in the mental health issues or conditions, but also expertise to deal with people with intellectual disabilities. As a conclusion, population-based studies investigating the relationship between depression, cancer, and ID are largely missing. And in the context of cancer, there is a need to bridge the gap between, first, it is a need to decrease stigma, how to decrease stigma, to educate people, to promote campaigns. And it is important to enhance the connection between oncology, psychiatry, to develop more targeted therapies tailored to this vulnerable population. So it's important to work as a multidisciplinary team, okay? Different backgrounds, different expertise with the aim to help and develop effective therapies for this population. So, and you see, just to finish, cancer services, like all healthcare services, need to be inclusive and accessible by everybody, including people with disabilities. Thank you so much. And this is the reference of the chapter.
Yeah, thank you so much, Dr. Lara Carneiro, and to you and your team, and my congratulations on your book chapter. It's a good input of CUPID project, dual diagnosis, cancer in people with intellectual disabilities and depression. is emerging field, and you did a great job with this presentation and with your book chapter as well. Thank you to you and to all your team. I shared all your collaborators on this presentation in the chat. So are there any question, remarks in the audience? Please, you can put them, your questions in the chat. If you don't want to appear with video or audio, are there any, or you keep them for the last session when we will have a broader discussion on all four presentation? Okay, if not, once again, thank you, Dr. Carneiro. Now I want to introduce the last but not least presentation by Dr. Tanja Sappok and her team from Germany. There are a lot of collaborators. I will share also all the collaborators in the chat, or she can mention if she wants. The title of the presentation of their presentation is Occurrence of Cancer in People with Intellectual Disabilities in Germany. So the floor is yours, Dr. Sappok.
Thank you very much, Vladimir. And can you see my presentation?
Yes, but please put it on full screen.
Yes. Okay. So is it okay now? Okay. I start right away.
I don't think so. It's
still not okay.
It's still not on a full screen,
Okay.
or the signal is has delay. I don't know. Internet connection. Please put on this button where was your yeah, down on the full screen. Yeah.
Yeah. But because of my different desktops, I think.
Yes.
It has a problem.
Yeah, it's a problem.
Yeah.
Okay, you can try with this, but
yeah.
You should click on each slide. I think so.
Yeah.
Okay, let's start.
You see now the next slide?
Yes. Yes.
Okay. So thanks again, Vladimir, for your warm welcome. And it's a pleasure for me to have the opportunity to present some very preliminary data from Germany. But before I start, I want to talk a little bit about the place where I'm working at. I'm from Bielefeld. Here in Bielefeld, we have a university clinic called MARA, where two different departments, the University Clinic for People with Neurodevelopmental Disorders and Epileptology, work together under one roof of the von Bethel clinics. And here's the other Professor Bean and the people from the nursing team who I'm closely collaborating. And in our department, we take care of people with intellectual disabilities, with internal medical problems, people who received surgery, and also people with psychiatric problems within one clinic. So the target group are people with IED, also those with acquired brain damages, with autism spectrum disorders, and complex, severe or multiple disabilities. As we have heard before, the cancer risk for people with intellectual disabilities is an important issue for concerning the mortality rates, and it is increased in some studies. However, some other studies say that the cancer risk may be decreased in this population. It seems to be independent of gender and independent of the severity of IED. Apparently, the risk of cancer is decreased in older people with intellectual disabilities and is increased for some tumor types. However, for some others, it is reduced. So let's have a look at the data from Germany. I was very lucky that I got access to the data from all outpatient billing data in Germany. So here the data from 65 million people come together, and of these, about 500,000 people have had an additional intellectual disability. We now matched those people with and without ID for age, sex, and the place they live. And in the end, we found that those, the general population, an incidence of 5% of cancer, while those with intellectual disabilities have had only the diagnosis of cancer of about 4%. This leads also to the results you can see in the forest plot here on the slide. The odds risks for cancer in the whole population we analyzed is reduced in those with intellectual disabilities. However, if you look at the different tumor types, you can identify certain tumors where we observe an increased risk. Especially high was the risk for CNS tumors, as you can see here, but also for the testicles and for the ovary, and for certain types of leukemia. Other tumor types seem to occur less often, such as malignant melanomas or tumors of the prostate, and also tumors of the breast, and of the lung. Interestingly, also in our sample, despite it was matched for age, the people with intellectual disabilities fall sick with cancer earlier than those without ID. Here you can see the prevalence rates, or the proportion of cancer patients with ID in blue and without ID in orange. And at younger ages, those with ID have more often cancer than those without ID, while at older ages, here it turns around at the age of 50 about, more people without ID suffer from cancer compared to those with ID. Our results are in line with some other studies. For example, here they compare the risk of different tumor types in people with severe developmental disabilities and compared it to those with only mild to moderate ID. And here also they found increased risks for tumors of the testis and also for the central nervous system and lymphomas, while those of the lung was less often observed in people with more severe intellectual disabilities. And also in the prostate, it was a little increased compared to those with only mild ID. In general, the life expectancy in people with intellectual disabilities is still decreased, and malignancies are one of the most important risks for death. The cancer-associated mortality risk is, according to different studies, increased in people with intellectual disabilities, also for various tumor types. people with syndromes are especially vulnerable to develop cancer, depending on the different, on the respective syndrome. And this may be due to overlaps in the genesis of the cancer and also of the disability. For various genetic syndromes, there are different studies that describe increased risks for certain tumor types, like leukemia or cancer of the testis in Down syndrome. However, not only genetic risk factors play a role, also non-genetic risk factors, such as reduced physical activities, nutritional factors, overweight, or chronic gastroesophageal reflux may play a role in the development of cancer. As Lara already pointed out, people with intellectual disabilities are often diagnosed at a later stage of cancer, and often the route of diagnosis goes via the emergency presentation and less often by screening. There are some studies concerning the treatment of cancer in people with intellectual disabilities, and apparently in different tumor types there are reduced treatment options. They are less operated, they less often receive chemotherapy, and often also the pain therapy is adapted in people with intellectual disabilities. The screenings for mammography or pap test or coloscopy are reduced in various studies worldwide in people with intellectual disabilities. In this population, we are faced with various challenges: structural factors, social factors, patient relation factors, and healthcare system factors play a role that lead to the disparities in cancer in people with intellectual disabilities and the worse outcome we observe in this group. Fortunately, the scientific interest is increasing in this field, and year by year, if you look for oncology and intellectual disabilities or neurodevelopmental disorders, we get more and more information about this highly vulnerable population. And 2 minutes before 2, I want to end my presentation. And I'm happy to hear your questions.
Yes, thank you for your comprehensive and very interesting presentation, especially the part where the genetics mentioned, because I'm the professor in human genetics among the other subjects, medical aspects of disability. So it's very interesting, and I hope that this preliminary study of Germany you will publish very soon on English in some journals. Are there any questions? Here I can see in the chat, Irena Stoyanovska. Thanks to all presenters for the wonderful work you're putting in this under research topic. How, in your opinion, will this new knowledge improve the approach to the health issues affecting persons with intellectual disabilities? Dr. Tanja Sappok, I think that is for you. Please stay. Now, this question for you, it's for you, I think so. do you listen? I cannot hear you. Please unmute yourself. Do you?
I'm sorry, I was distracted. Here,
Can you read
I
in
read
the
it
chat?
in the chat. Yeah.
Yeah, please,
How
because it's not good to repeat.
Will this new knowledge improve the approach? Yeah, I think it's important to not only speak of cancer, but to individually find ways for the different cancer types in people with intellectual disabilities. And it also may have an impact on the age of onset of certain screening measures for different cancer types. For example, there are people who say that maybe mammography in people with Down syndrome, as they apparently have less often breast cancer, can be a little bit delayed, while those information that the people develop cancer at earlier ages is relevant to maybe start the screening examinations a little bit earlier for other tumor types. And you really have to interpret those results I showed you in the first block with caution, because for example, we found less cancer of the gastrointestinal tract, but this may not be a reduced prevalence rate, but a reduced rate of diagnosis. That's a big difference. So we may even look more carefully for colorectal cancers in people with intellectual disabilities, as it's diagnosed probably too seldom in our population. And so there are many different issues that need to be acknowledged when interpreting these results and putting it into practice.
Okay, thank you for your additional explanation. I hope that my colleague Irena Stoyanovska will be satisfied with your answer. I hope that Dr. Denis Harputlu addressed the question to you. Thank you for the presentation. Do you have any data to compare the stage of cancer during the diagnosis with IDs and without IDs?
No, I showed it, others have done it. As I showed in my presentation, apparently people with ID are diagnosed at a later stage, but from the data of those billing, of the billing system, we can't say anything about the stages. When I can share the impression I have from my clinical practice here, I must say most of them are diagnosed at a later point of time.
Okay, thank you very much. Now I will ask all the presenters to appear with the cameras and only the audio will be turned on only when and I will ask my colleagues to make one common photo for the people who are only the presenters. I think that, but okay, for now you can turn all of the participants. In the maximum we have 72. At this moment we have 63. I will ask my younger colleagues to make one common photo for all participants, and after that I will ask only the presenters to stay with camera. The other I will ask to turn off the camera, and I'm opening the session of discussion and questions. Please don't hesitate to put your questions on chat, or we already have 2 questions to Dr. Sappok, but now it will be nice. Okay, I think it's enough. Please, now you can turn off the cameras, only the presenters. It will be enough I want this webinar to be much interactive, and I will wait for a minute. If there are no questions, probably I will start the conversation. And also, I will ask the presenters, they could be to feel free to ask in between each other some questions or give some comments or remarks. Okay, there are no questions for now. Probably I will start
Hello,
with
everyone.
Yeah.
I hope you can hear me.
Please, who is talking? You don't raise the hand. You don't
Just
raise.
a moment.
Alexandra Shuminovska, okay?
Yes, that's me.
Yeah,
Is it
my
okay
former
if I
student. Okay,
ask
let's
a question with audio?
Yeah, it's okay.
Okay. First of all, thank you for selflessly sharing your knowledge with us today. I would like to ask a question that is mostly connected to the first presentation. So I think it is very important to adapt the hospital environment to be welcoming for the people with intellectual disabilities. So my question is, according to the research, what are the best ways to do that? And did the co-researchers with intellectual disability give some ideas on this topic? Thank you so much.
Can I answer?
Yes, of course. It's about your presentation. Thank you so much.
All right. Our co-researchers with intellectual disabilities, of course, had different ideas, but as we mentioned in the presentation, the most important was to raise awareness. But they also talked about healthcare professionals who weren't very friendly for them. They also had some ideas, for example, to introduce healthcare to institutions where they participated, for example, to occupational therapy workshops. They wanted to have some conversations with specialists, and there were quite a lot of them, quite a big number, who talked about the need to be more independent in the relationship with healthcare professionals. For example, they were sometimes very angry when the doctors or nurses talked only to their parents and not to them when they came just to hear the diagnosis or to treat some kind of illness. I hope that I answered your question.
Yeah, I hope.
Yes, thank you once more.
Yeah, thank you, Alexandra Shuminovska, for your very interesting question. And I encourage the other participants to take the floor, to not shame, or if they want to give the questions with audio, they can type it in the chat room, in the meeting chat. During we are waiting the question, probably I have for the second presentations for Dr. Suzanne Denieffe and Dr. Margaret Denny about the co-production, and because I'm the leader of the fourth group, we prepared and it will be nice to announce to all CUPID members and to other participants. We prepared one common article, and both of you are the leaders about the co-production. And in which stage are that article, which we talked in a Gdansk meeting last October? Probably you are finishing it. Can you tell us something about that?
Certainly, Vladimir. So that article is still in progress. We initially, as you know, Vladimir, we had set out to look at how to do co-production with people with intellectual disability in relation to cancer prevention. And there was no papers at all about this topic located. So we weren't able to do that scoping review. So we changed the question. And the question then became, what is the best way to do co-production with people with intellectual disability? And again, we did a full systematic search to find papers. We've only located 16 papers, which really isn't a lot. And these papers are talking about co-production in lots of different areas, in relation to intellectual disability. So what we're doing is we're pulling together the key themes from those papers, and we hope to have the paper finished within the next 2 months.
Very nice. Thank you for your very concrete answer. And I really hope that this article will be submitted in the next 2 months. And also I hope too that it will be published in some good journal, impact factor journal, or this article will have a great impact to the field of cancer and intellectual disability. Okay.
And Vladimir, if I could just make it an additional comment, and this is kind of relevant to across the CUPID action and indeed outside the CUPID action, there is the European Cancer Organisation have an inequalities network contained within it. So the European Cancer Organisation is based in Brussels. It has representation from almost all the countries in Europe. So the CUPID project is now linked in with the inequalities network. And therefore, Margaret and I presented last week about CUPID on that network, and they were very interested to hear about the CUPID project and are looking forward to seeing what our outputs are. And if anyone on the webinar is interested in getting involved in the network, you just link onto the website and you can join that network of inequalities linked to the European Cancer Organisation.
Yeah, you have to be accepted into the group, and we are very fortunate to have Dr. Professor Grabovich from the University of Vienna. He's coming to our training school to give a talk on behalf of the Inequalities Network and his own work in terms of inequalities within cancer prevention. So very.
These are very fruitful informations for our members and also for participants who attend on this webinar from outside. Thank you very much for sharing this nice information. And Dr. Ivan Matthews says, sounds like a super paper, Suzanne, in the chat. Are there any other? To Dr. Carneiro, again, from my former master student, Irena Stoyanovska. Do you have any insight in the frequency of depression in ID and neurodevelopmental disorder persons with cancer in comparison to general cancer suffering population? Do you have any insight, Dr. Carneiro, in your research?
So thank you so much for your question. If I understood in the correct way, when I compare with general population with people with ID, the number of the numbers concerning depression, the percentage of people that have depression in people with ID. That's it. Question? Can you please confirm? So if it is, it depends of the type of cancer that we are talking about. Okay, we know that the percentage in general population, the percentage of cancer is high. Not only the depressive disorders, because when I'm talking about depression, it's a broad spectrum. Okay, the most prevalent type is major depressive disorder, but the percentage is huge, not also in concerning depressive disorders, but also anxiety disorders, because anxiety disorders, they appear as a comorbidity of psychiatric, affective disorders, major depressive disorder, for example. But the papers that I have been reading, it's about 35%, 40%, but it depends again on type of cancer that we are talking about, okay? And the percentage is similar, okay? I believe
it was the question. I hope that you covered the question. Thank you so much. According to the dissemination rules of cost actions, we should upload the presentation on our CUPID website, and I received 3 presentations until now. And I will ask the 4th presentation to send me immediately after this webinar, and you will have all those presentation open access in PDF format of all these 4 presentations from today. So you can share it with your colleagues, friends, and our role of dissemination and outreach will be, I think, good. I also encourage all of you presenters and all other CUPID participants to write scientific articles on this topic, cancer understanding prevention in people with intellectual disabilities. So also I want to mention, because we don't have any other questions, I want to mention that probably in October we will have annual conference on the end of the 2nd year of the CUPID action, and each working group, there are four working groups, each leaders will give a short presentation on the results of their group in the 2nd year. So we are going to the end of this scientific webinar. We planned 70 to 80 minutes webinar. There are one more. Okay, it's a direct message. I will read it again, and it's for me. Are there, from the presenters, are there, because I will close, from the presenters, are there any other comments or which you want to say for the end of the of this webinar? Do you want to add something?
Just to thank you, Professor Trajkovski, for organizing this seminar. It was very fruitful, and thank you so much for organizing it.
Thank you too. From the other presenters?
No, as chair of the action, Vladimir, I really do want to thank you. It takes a lot of work to organize this seminar. You've done so with great aplomb, so thank you very much for all your work.
Yeah. Thank you too for contributing, for your 4 very, very interesting and very inspiring presentation, which will be a good fuel for the next 2.5 years until the end of the project. So if there are no other comments from other, I will go into the final words as a moderator of this webinar. I would like to thank to all 72 participants who attend on this. Again, I proved that my thoughts that 50 to 60% from on each seminar or webinar from the registrants are presented, and those today it was proved. We have 72 from 138 registered participants. Also to 6 of you presenters, great. I'm very grateful for your contribution today, and I hope that this webinar will have impact. And during your presentation, I share all the social media and CUPID YouTube website, where you can find the link of this webinar. Afterwards, it was live today, and afterwards you can share with all your colleagues who cannot attend on this webinar for some reason today. And at the end, I want to thank to my collaborators, Andrea Ivanovska, Irena Stoyanovska, and Natalia Velichkovska, who were, you didn't see them, but they were responsible for making some posters, for making print screens from today's webinar, for making streaming on YouTube. So it is not only my only my job, but I have my collaborators, and I would like to thank all of them. I hope that we will see in the similar format in October at the end of the 2nd year. And also we between the CUPID members, we will see on some next meeting, MC meeting, or meeting in the frame of the working groups. Okay, around 80 minutes. Thank you very much for your time. I wish all of you health, to stay healthy in the following period. We are in the ending of the academic year, on the session in the June. And I hope that you will stay productive in your cancer understanding intellectual disability work. So thank you very much, and we will be in touch by emails. Have a good afternoon and nice weekend. It's Friday. Enjoy the weekend. Bye-bye.
Bye.